It seems that early and extreme social distancing has flattened the curve around the country and the world. Now what? In this episode of Life Prescription, we talk to infectious disease expert Dr. Chris Tymchuk about what we need to know in order to get to a post-stay-at-home world. We cover a lot of information in this episode, and you can click the description below to jump to the sections that are important to you. I've also linked a couple videos I've made earlier that are highly relevant to this discussion. One examines why Italy's death rate is so high and is a basic review of some epidemiologic concepts. Another is about the role of chloroquine and hydroxychloroquine in treating COVID-19. I made it a few weeks ago, and funny enough, it's more relevant now than it was then. If you find this video helpful, please share it with your friends and family. Also, please click the like button. It will help other people find this video. So, okay, welcome everyone. We're now more than 3 months out from identifying the virus, SARS coronavirus 2, which causes the disease COVID-19. But we have a lot of questions that are unanswered, and these are questions that we need to answer if we're going to get back to our daily lives, back to visiting our friends and family, back to getting Dr. Tymchuk's kids at school, back to opening up our economy without risking widespread circulation of the virus and overwhelming our hospitals like what happened in New York and Detroit and New Orleans and all over the world. So today we're very lucky to have Dr. Chris Tymchuk help us understand where we're at in that process. He is a physician practicing in the fields of internal medicine and infectious diseases. So Dr. Tymchuk, I know you're very busy. You're actually in your office right now, so thank you for taking the time to chat with us. So
happy to be here. Thanks for having me.
We're extremely excited to have you. So we were talking about that diploma on the wall behind us where you did your residency. So you did your residency in internal medicine. You did your fellowship in infectious disease. You also have a PhD.
I do. So before going to medical school, I started off sort of in a research teaching field in prostate and breast cancer. And then through that, as I was working with cells and PCR assays and mice models, I realized I really wanted to work more closely with people. So I ended up applying to medical school and went into medicine, and I was in medical school in UBC, British Columbia, where my family's from, and then finished medical school there, came to Los Angeles, where I'm from, to UCLA for residency in internal medicine, finished that in 2007, and then spent a year living and working in Malawi at an HIV clinic. And from that has sort of arisen our elective in Malawi for UCLA residents, and then a pathway training program for medicine residents, and then did my fellowship in infectious disease and have been a faculty member at UCLA since 2011, practicing in both internal medicine as a hospitalist and then infectious disease.
That's amazing. Yeah. And so actually the UCLA Global Health elective for the internal medicine residents, where they go to Malawi, that was started by you. I didn't know that.
Yeah, so I was the first resident to go, and then through some of our faculty who had connections at this amazing clinic, and I was the first resident to go, and then from that experience, with the help of Risa Hoffman in infectious disease, we developed an elective, and then Risa sort of led the elective, and then when I kind of took over that role, I helped develop things into a pathway along with some of our other faculty.
That's amazing.
Yeah.
Okay. Wow. So not only are you an infectious disease doctor who's an expert in these times, you've also contributed a lot to the educational environment of the residency. So that's pretty awesome.
Yeah.
So in today's episode, all the questions that I'm going to ask you, Dr. Tymchuk, are coming from the viewers and listeners of this channel. And if you have questions for Dr. Tymchuk that we don't answer during this episode, you can leave a comment in the comment section below, and we can try to answer those after the fact. If you're listening to this as a podcast, you can tweet me at skheartdoc, and I will try to get back to you. So the first question is from basically everybody I know and myself, which is, are we ready to reopen the country? And if not, what do we need to do to get there?
It's a great question. I think that we're still seeing an increased number of cases, not increased number of cases, but we're still seeing a fair number of cases, both in California and New York, where we've seen them a lot over the past several weeks and month. And we certainly need to see us going past our peak. It seems like New York has gone past their daily number of cases, peak of daily number of cases and daily number of deaths. California, there's some suggestion that it may still be on the upswing a little bit. The model that I've relied on the most is through University of Washington. And they've projected that if the number of cases get below a certain level, which they're expected to in California by mid-May, then it may be safe to start to do a graded reduction in the public health measures that we're taking right now. And then for New York, because they've had a higher number of cases, they're looking at early June potentially. The other aspect of that is what are the measures that would still need to be taken to make sure that it is safe to gradually reopen our economy and our social activities. And a large part of that revolves around the amount of testing that can be done and is available, because to be really truly effective in trying to identify active cases, it's helpful to have widespread testing, but then also personnel who can then track down and trace the contacts of that person. Interestingly, with this virus, it looks like it actually is contagious 2, possibly 3 days before a person actually has symptoms. And so if a person develops symptoms and it turns out to have the virus, you would actually have to go back and trace their contacts for 2, possibly 3 days before they had symptoms. So more widespread testing, potential tracing of infected contacts of the infected person. Those are some of the big things. There are some treatments that are being studied, and I can talk a bit about that, but one of the potential benefits to some of the treatments is that they could potentially be used as prophylaxis. For example, we have a great medicine for influenza that if someone's exposed to somebody with the flu, we could give that treatment to an exposed person. It prevents it in most cases, and we're looking at developing a similar medication for the novel coronavirus.
So I think most people would have that understanding that as of right now, today, in California and New York and these places, large metropolitan areas, we're not ready to just open up get rid of social isolation, open up all the restaurants, etc. And at least as our current understanding and your current understanding, we're probably about a month away from going back slowly and seeing if we can reintroduce these activities in California, probably a couple months in New York. And then we need to set up the infrastructure for testing, tracing, isolation, while at the same time we're waiting to see if there are any existing treatments or medications that we can take to prevent getting this virus in the first place. Does that sound about right?
That's a great summary. And the other aspect I would include is ultimately the development of a vaccine, which we can also kind of talk about as well.
Yeah.
The other really important factor in this, I think, is, I'm coming at this from a physician, clinical, hospital-based perspective, where we have the potential to have a surge of patients that could potentially overwhelm our resources, which hasn't happened so far in LA at our hospitals. But the other aspect to this is the impact on people's livelihoods, daily lives, their education. There's other impacts that need to be considered and weighed in balancing these decisions. And again, we rely on our political leadership to help guide us through these decisions, but sometimes they're not always made with as clear scientific guidance as I would hope.
Yeah, that's difficult, because for you, for us in the scientific medical community, the questions that we're trying to answer, our understanding, the path forward is not certain, right? We have, a good understanding of how we got here, but the path forward is not certain for us. And so I find in my own clinical practice, if you give someone good news, if you give someone bad news, if they have news that's concrete, it's easy to process. But when you're in that middle period, like, is this treatment going to work? How long do I have to live, et cetera? That's very hard. And this is for everybody. The entire world is dealing with this exact question.
I completely agree that a lot of the challenge of this entire situation is the unknown. this is something that we have not dealt with for a century, realistically, and the way that our culture and society and medicine is now is so completely different that we are able to take different approaches to things. But I think that it's using our best models, most knowledgeable people to help guide these decisions as best as possible, and then adjusting things as you kind of make decisions. To be honest, I have been really amazed that we actually essentially almost completely shut down our entire country and much of the world in terms of schooling, economies, travel. It's truly unprecedented. And I think it's had some real benefits. I think we can attest to the number of cases in our hospitals being manageable and fairly steady. And I think this is a direct result of a lot of the measures we've taken. But it's unprecedented. And the way forward, as you say, is not completely clear. But we have some pretty good models and some pretty good science to back up how to approach this rationally.
Yeah. So I hope that we can have that collaborative kind of interaction between, politics, business, science, and medical communities to try to pave that path forward, adjusting according to the evidence, which is pretty much how we approach all of our scientific and clinical endeavors. So,
yeah. And I also wonder how tolerant people will be for this much longer.
Yeah.
And if things did flare up, how willing people would be to go back to where we are now.
Yeah.
No, some people maybe, some people not. But it's all going to have to be taken into consideration.
Absolutely. And that's not to ignore there's going to be a lot of pain, a lot of disruption. For example, you have kids at home, so now you're going to work, but then your kids are not at school, so you have to figure out daycare, you have to figure out how they're going to get their schooling. A lot of people are, obviously, there's tens of millions of people unemployed now. Lines to the food bank are, around the block. Like this is a very, very difficult time for a lot of reasons. And so there's a lot of questions that we have to ask about how we can move forward safely, but also by supporting the livelihoods of all the people that are affected. So the next question we have is from RJ in California, and this is, he asks, is there a risk for a second wave? So I think this is a question that's on a lot of people's minds. We've seemed to flatten the curve around most of the country and a lot of parts of the world, but what happens next? Is there a wave? Is there a risk for a second wave?
So it's a great question. So I think that knowing about respiratory virus biology, including coronaviruses and other similar viruses, including influenza, these often become seasonal. And the original coronavirus was SARS, which occurred in 2003, and we were able to follow all contacts and trace down all contacts for that virus, and essentially it's gone away and has not come back. But that was much more narrowly spread. It was transmitted later in illness than this virus seems to be. So this virus has now become much more widespread globally, and I don't think that there's any real chance that this will go away entirely. I think that it will likely become similar to other viruses that tend to circulate in the winter months in the northern hemisphere, in the tropics and the equatorial regions year-round, and then the southern hemisphere during our summer months. So I think that there's a fairly good chance that this may come back, and it may come back a little bit as we lighten some of our public health measures. I'm expecting it to kind of die off a little bit by summer, but I think that given its global transmission at this point, it's highly likely that it will sort of resurface, to me at least, that it will resurface later on in the year around the time of influenza and other respiratory viruses. For the foreseeable future, for the next few years, we may be dealing with outbreaks of this as it kind of comes back periodically. The long-term vision is that we will have a vaccine for this that has some efficacy and that we can ramp up the production of the vaccine to then be able to provide some general protection for this and keep it at low background rates. That's sort of my thoughts. Again, it's challenging to know, but with other respiratory viruses, that's what I would be thinking.
Yeah. And again, we're adjusting our models, we're adjusting our recommendations based on the information that comes to us. And it's kind of inspiring to see almost the entirety of the scientific and medical community trying to tackle one question. I've never experienced that in my entire life. Obviously, medicine and science changes, like things I learned in medical school not very long ago, are now wrong, like, which, if you're not in medicine, sounds crazy. Like, why would you learn something that's wrong? But it's being adjusted according to the evidence. And now that's happening literally by the hour. I can't keep up with any of the literature that's coming out on coronavirus. And so having to adjust that, having to move forward, and you're saying that thinking about a second wave, maybe later on in this year, maybe timing with influenza, those two coming together at the same time, influenza, which happens every year, the regular flu, influenza with COVID-19, sounds to me like it could be a lot worse than, and the CDC has said the same thing, could be a lot worse than what we experience now.
Yeah, it's a good question. One of the analogies or parallels that I'll draw is between, we know that dengue and malaria in some of our partner sites in Peru tend to coexist it's transmitted differently, so it's not exactly perfect, but they tend to not happen at the same time. It's almost like there's competition between the two in the human host, and they can't quite both happen at the same time. It's possible something similar might happen in this situation. We found in most of our patients that if they have coronavirus, they do not have another respiratory viral infection at the same time. So you might expect that there could be a wave of flu and then it kind of dies off, and then a wave of coronavirus, possibly both at the same time, but probably two separate waves. But again, that's also concerning that the influenza already is potentially deadly each year to a certain number of people, and then if you have coronavirus either on top of that or as a second wave, it's concerning.
One thing I was going to bring up leads us exactly into our next question, which is obviously a lot of people have been infected across the country and the world. We don't know exactly how many, but one question I think that's on a lot of people's minds is, if enough people have got infected, could that confer immunity to enough number of people that we can stop? So that's the question from Dave from California. He's asking, what is herd immunity and will that protect us?
So the other phrasing for herd immunity is community immunity. And essentially the thought is that if a certain percentage of a population is immune to a certain virus, either through vaccination or through a previous exposure, that it actually diminishes the likelihood that someone within that community can become infected with that virus. And so measles operates under similar approaches, polio, influenza is one of the more well-studied viruses. So essentially, we have good studies that show that for influenza, which is probably the closest virus, analogous virus, that if 25 to 50% of a population, for example, in a school population, are vaccinated or immune to influenza, then it diminishes the likelihood that another kid in that school can become infected with influenza by about a third, by about a half. So as the greater number of people become vaccinated or immune to a respiratory virus, the greater the protection for other people in that community. And we see this each year with influenza in particular, that we advocate for people to get the vaccine as much as possible because it protects everyone in the community. And the corollary to that is that as people do not get the vaccine, that less people are immune and there's a higher likelihood that people can get infected. And how that pertains to coronavirus is that at this point, the best estimates that we have are in California, that around LA County and Santa Clara County, where they've done the two studies, that around 4% of the population has been exposed to the coronavirus. So that's still a relatively small percentage of the population. The other is that we still don't know that just because you've been exposed to it and been infected with it, that you're actually immune. I think there's good reason to believe that will have some degree of immunity, but we don't know that with certainty about that. So we're not close to those types of herd immunity levels just yet. It really will take an effective vaccine, I think, to get us up to beneficial levels.
So, 25 to 50% of people needing to be infected by seasonal influenza to achieve something close to community immunity. Whereas now we can estimate about, in the single digits of people being infected across the country, which to me sounds like nowhere near where we need to be to get community immunity to coronavirus.
That's right. So I don't think I would take, the other part to that is I wouldn't take community immunity or herd immunity into account when we're thinking about reducing the public health measures that we have right now.
Got it.
Yeah.
To me, also, another point is to get to, say, 50%, that seems unacceptably high. If we've already dealt with this number of mass casualty and hospitalizations and overwhelming hospitals, and at 5%, for example, 50% seems unimaginable to me.
It's a good point that, part of the studies that have been looking in LA County and Santa Clara County were looking to see how many people who have minimal symptoms have actually been infected. And it turns out so far more than we realized. But I agree, for that to then get to 50% would mean that a lot more people would likely be sick and hospitalized, and could be a real challenge for our healthcare system. Yeah.
I want to touch also on the point you brought up that hopefully, people get infected, have immunity now. So where are we on our understanding of people who get infected? Do they develop antibodies that confer immunity?
That's a great question. I don't know great studies that have looked at that yet or come up with strong evidence one way or another. What I would say is that at UCLA right now, we are looking at this phenomenon of convalescent serum to help treat patients with coronavirus. And essentially that's a concept where we know in most people who are exposed to a virus, historically it's been things like Ebola or other viruses, that if we take their blood and separate out the part that has the antibodies or the immune system response to the virus and give that back, we test it to make sure that it's not infectious for other viruses, and give that to someone who is very ill with coronavirus or another virus, that it can have some benefit in treating that underlying illness or that virus. So we're actually starting to do that right now with coronavirus. And I just heard last night that we have our first convalescent serum ready to give to somebody. And our chat among the infectious disease faculty today was of these 8 patients who are we going to give it to, and there are different aspects about how we approach that. But so the short answer is we don't know for sure, but we're actively investigating that right now.
It's awesome that we can be a part of that trial to see if convalescent plasma, which has been in the news a lot. Again, like you said, it's a blood product that, so if I got, let's say you got infected and you recovered, and now I'm in the ICU, I take and separate out your antibodies from your blood, put it into my blood, and hopefully that will help clear out the virus in me. So that's awesome that we get to be a study site. I really hope that we can find something, because so far it doesn't look like we have any definitive promising treatments or prophylactic medications for this virus.
Yeah, and I would say that this sort of comes back to your point earlier about how the medical scientific community is really gathered and rallied around this one problem like we've never seen before. One of my mentors, Otto Yang, who I did research in his lab, he's a virologist who does assays with viruses in the labs. He is now formed and is helping to run these clinical trials for convalescent plasma and serum. It's really remarkable. And the other part to your point is that at this point we have about 8 or 10 clinical trials going on at UCLA looking at antivirals, anti-inflammatory, other types of treatments for coronavirus. And it's remarkable what we're doing. But again, so far, none of them have clearly shown any evidence of benefit at this point. I'm hopeful, but at this point, no clear data. Yeah.
The next question comes from Farhan, also from California. He asks, is the virus mutating? Are there different strains around the world? And could this explain different rates of infectivity and mortality?
It's a great question. So there's a lot of sort of technical things that I could go into about how the virus mutates and how quickly. But what I would say is that it is mutating, and as all viruses do, especially as they get transmitted from person to person. But in general, these types of viruses have to trade off. They have to essentially trade off how infectious they are with how severely ill they can make a person. In general, as a virus becomes more easy to transmit, the less severe it tends to make people illness-wise. And there have been researchers who have been looking at this primarily at UCSF who have found that there are essentially variations in the virus as they've kind of circulated around the globe and in different US populations. But as far as we can tell, there's not much of a difference in how it impacts someone's illness. And I don't think that is a major factor in why certain people get sicker than others.
Yeah, because I think that's so yes. So there are different strains, but we don't know. But it's not clear that that's causing. That's the reason why we have differing mortalities in, say, like Italy compared to Los Angeles, or Wuhan compared to Shanghai, for example.
Yeah, and I would clarify. I don't know that I would say that there's different strains necessarily. I think that there's differences enough that we can detect those when we look at very minute differences. But in terms of an actual strain, it's probably very similar to how the initial virus was. And I think that the major factors that account for the difference in mortality regionally are probably local regional factors, healthcare system, age of population, comorbidities, those types of factors. Comorbidities like high blood pressure, diabetes, obesity, those types of
well, that's actually one of the biggest reasons that I'm so invested in this is the people who seem to be getting the sickest or who are at the highest risk of having severe complications are the patients that I would be treating, the people who have diabetes, high blood pressure, existing heart disease. And it seems to be a two-way street. It's like these are the people who are at the highest risk. And also having the high inflammation, infection can trigger acute coronary disease. And so for me, it seems to be more urgent than ever that we have a conversation about prevention of these metabolic diseases, of these cardiovascular diseases. So, and especially if this isn't going away. So speaking of cardiology, this next question is from Twitter, and it's from Tiffany Hu, a former resident of yours. She's currently at the Mayo Clinic doing her cardiology fellowship, and she asks, well, she actually asked, why is this different than SARS, which you hinted at earlier. Her specific question is, why is it different than the SARS pandemic that occurred in 2003? Were there differences in the R0, public health response, incubation time, all of the above?
The big difference, as we're starting to find out, I think, is that, and we could tell epidemiologically, is that this again, SARS, this is a SARS virus. They're both very similar, but slightly different in terms of the way that they're formed and the way they're transmitted. The SARS from 2003 looks as if it was most infectious several days after the onset of symptoms, and that there wasn't much transmission prior to onset of symptoms. There's a really good Nature Medicine paper that just came out from researchers in China, Dr. Liang and others, and they essentially pointed this out for SARS, and then now they're looking at this novel coronavirus, and it looks like it actually is transmissible about 44%, so almost half of transmissions happen in the 2 to 3 days before symptom onset, and then for a few days after symptom onset, there's still some transmission. So it's not necessarily that this virus is infecting more people from each person who's infected, transmitting it to more people. It's just that the person who's infected doesn't know that they're infected because they have no symptoms, and they are shedding virus through their nose, and they then transmit it to somebody else, and then they start to have symptoms, and then they go, oh no, I have a virus, and then they might start to stay at home at that point. But before then, they've been at work, they've been at school, they've been spreading the virus around. Yeah.
That's fascinating. I did not know that. So this delayed kind of incubation period could increase the amount of people that you have infected. So it may not be more contagious. It's just that people didn't know they had it.
That's right.
That's fascinating. Okay, so thank you, Tiffany, for your question. Mina in New York asks, if there's such a big delay for a vaccine, some estimates are a year, some are a couple years. We don't really know at this point. What are we waiting for in terms of ending the lockdown? What makes it safer to go outside in 4 weeks than 2 weeks if we don't have a vaccine?
It's another great question. So, the best estimates that I can read and from experts and based on prior experience is that an effective vaccine is likely at least a year away. There are ways for that to be sped up, but we also want to make sure that it's as safe and effective as possible. The other issue after that, again, is ramping up production of the vaccine. That is that if we want to try to provide the vaccine for potentially tens or hundreds of millions of people in the United States alone, that could take another few years as well. I think that has two impacts on the pandemic. One is that this will likely play out over the next several years and kind of keep coming back and going away and coming back until we have an effective vaccine in place that we can vaccinate a significant proportion of the population. Again, 25, 50, 75% of the population we don't know. And it depends in part on the efficacy of the vaccine in protecting people from getting infected. The other plays into the short term, and the vaccine thought doesn't play into the short term whether we take off the public health measures in 2 weeks or 4 weeks necessarily. It won't be a factor. Really, the 2 weeks versus 4 weeks of further public health measures plays a role into our capacity in our healthcare system to manage any surges that might happen as we reduce some of these measures that we're taking at this time.
Okay, so it's two completely different timelines. One is a long-term play, and one is what do we do right now to not let our hospitals get overwhelmed.
Yes. And
you were mentioning the metric that we used to guide at the beginning of the episode was to see a decrease in the overall number of infections in a certain region before you can ease isolation measures.
That's right. And there are ways to look at what number of cases per day we should get below. And there's if you get below a certain level, then it's predicted to rise at a certain rate again. If you get below another level, it's predicted to sort of stabilize. So there's different projections and models below which numbers we need to get. And we're not quite there just yet for the numbers.
That's very helpful to know. I think understanding that may make it a little bit more palatable to people to say, this is why we have to stay inside. This is why we can't go out to a concert or to a restaurant, knowing that it's a question of life and death. So
the other aspect of that, and I completely agree. I mean, we were talking that I have 3 young kids at home, and we're sort of doing homeschooling right now, and it's been a real challenge. And I would love for us to be able to go outside and schools come back into session. But again, I understand the necessity for this. I would advocate for that as much as possible for the near future. The other aspect I'm blanking on, but if it comes back to me, I'll come back to it.
In the meantime, Piotr from Texas asks, why is there such a wide spectrum of illness? Why are most people completely fine, as you mentioned, like almost asymptomatic, and some people have severe disease? And in particular, he wants to know if there's any update on children, babies and children, who thus far seem to be less susceptible to severe complications of the illness.
This is a great question. It actually leads into the point that I was forgetting from the last one.
Perfect. Thank you, Piotr.
One of the concerns is that the highest risk of severe illness and mortality is among people who are older. So one of the biggest risk factors is people who are in their 60s, 70s, or 80s or older. And if you look at the mortality or the percent of people who die based on their age with this illness, people who are over the age of 80, around 1 in 6 people who acquire the virus that we know of so far actually can die from the infection. That percentage will probably go down as we find out that more people have had it and some are less symptomatic than others. But this plays into the concern that even if you're young and healthy and at low risk of having a severe outcome, you could potentially acquire the virus, shed it without knowing, and transmit it to someone who's older, and they have a higher risk of dying. So that's part of the reason why all of us as a society should be trying to follow these public health measures. The other part of that question was related to younger people and children. And so far, the best data that I've seen suggests that people who are younger and children are less likely to have bad outcomes with this viral infection. And we've seen that with a few cases that we've had at UCLA of young children who have had the virus and have done well. There was a good paper of cases of children infected with the virus from China, and essentially all of them did well. Having said that, there have been a few deaths of young children. So it's an important point that just because you're in your 20s and otherwise healthy does not mean that you will absolutely not have, or absolutely zero risk of having a poor outcome. It could still happen, but again, it's much less common than it is for someone who's old. And thankfully, just along those lines, the other analogy was H1N1 influenza in 2009. There were poor outcomes among pregnant women, or poor outcomes among children. So it isn't always guaranteed that people who are otherwise younger and healthier do better. It just happens with this virus, with its biology, for whatever reason, children seem to do better.
Yeah. So it's probably reassuring, especially for someone like you who has young children, probably reassuring to our pediatric colleagues that children seem to be less susceptible to the severe complications. But what about, for example, if, let's say, schools opened up for the rest of the year, those children are still coming back home where you are, where they could be going around the community. They could be spreading it to other people. So it's not necessarily that they don't get the illness. It's potentially that they don't get a severe disease.
That's right. That's right. So the children in areas where there's ongoing community transmission are very likely acquiring the virus or getting infected. It's just that their symptoms are likely more mild and we may not recognize it. And there is a significant risk that they can transmit it to someone in a household who's older or immunocompromised, and that would be a concern. And again, from firsthand experience, I've gotten many respiratory viruses from my children, and I can see it happen in one child, then the next, and then my wife, and then me. Yeah. So within a household, these things get transmitted very easily.
What about, so for example, I was shocked when I saw there's a hockey player, pro hockey player on the Edmonton Oilers named Colby Cave, 25 years old. This is an elite athlete, young, healthy person, 25 years old, who died from COVID-19. And as we're talking about, it's very clear that on these epidemiologic studies, the mortality rates are much higher for people who are older and who have medical conditions. But what about people like that in their 20s, young, healthy? Is there something that we understand about the virus itself or our immune response, or is there something that we can identify that says, why is it so unpredictable? Why is it so asymptomatic in one person and so fatal in another person?
It's a great question, and there's lots of aspects to that. One is that it's very likely an interaction of the biology of the virus and the host immune system. And we don't know this for so many different respiratory viruses that influenza, for example, every year, no matter what circulating strain of the virus, we see people who are otherwise young in their 20s and 30s who are critically ill in the ICU and sometimes don't survive. it happens every respiratory virus season. In terms of coronavirus, the novel coronavirus, it does seem to set up a pretty intense inflammatory cascade in some people that then leads to this inflammatory response in the lungs that requires a breathing tube and a ventilator to help oxygenate their lungs and their body. And it's very difficult to at this point to know who is at higher risk than others. Again, we tease out some factors: age, obesity, hypertension, diabetes. But if somebody has none of those, but still does poorly and gets critically ill and dies, there were likely other immune factors related to that. But again, we can't predict that or test that for every person. The other aspect of that I would say is it's a good reminder that respiratory viruses in general can make almost anybody, there's a chance for someone to get very sick from them, but it's a relatively rare occurrence, both for coronavirus and for influenza.
That's right. Yeah, we're talking about more than 80% of people who get coronavirus, who get COVID-19, will not have to interact with the healthcare system at all. And the number of people, as far as we know so far, who have these severe complications is around 5%. The 5% ICU rate is what I'm seeing.
That's absolutely right. So, and then the middle 15% that sometimes require hospitalization and a little bit of extra oxygen and close monitoring. And our experience, that data came from the initial experience in China. And I will be interested to see how our experience plays out here at UCLA and in the US. So far, most of our patients that have required hospitalization are getting better and going home. And those are the sickest of the community patients. So I think as we find out more about how many people are actually infected, how many people actually have symptoms, those numbers actually may end up looking better. It might end up being 90% get better and do fine versus 3% require ICU. I don't know, but based on our experience, I would certainly say that it's not more than 5% get critically ill.
Awesome. And this next question kind of relates, it actually does relate to, asymptomatic carriers bringing virus home, for example, kids going to school, etc. Natalie in Texas asks, is there an update on how the virus spreads? Has our understanding changed from in the last couple of months? For example, how long does it last in the air? What kind of surfaces is it? Is friendly to the virus, and for how long can we expect the virus to be on the in our homes, on our kitchen countertops, or our Amazon packages like that?
Good question. And first of all, I like that we have a real national audience, that people from across the country are sending in questions. It's great.
Well, so far it's a small channel, so it's mostly my friends who are just texting me. But,
we'll spread it more widely now.
Yeah.
There have been a handful of studies that have looked how this can be transmitted and how long it survives both in the air and on surfaces. And to the best of our ability, it is really through what are called droplets, which are essentially spread when people talk, cough, or sneeze into the air. And most of the droplets are large enough that they can't go beyond, and we're saying 6 feet, but in medicine, nothing's concrete. So 6 feet is sort of the cutoff where most droplets cannot go beyond. It's unlikely that the virus can survive in the air long enough for there's essentially a cloud of the virus that you walk through and inhale it and then acquire it that way. There have been some studies that suggest that's a possibility, but to date, there have been very few documented cases of that actually happening. And then there have been some scientists who've looked at how long the virus can survive in droplets that get onto surfaces. Plastic, metal, and then copper, cardboard are sort of the four things that people have looked at. And in cardboard, it doesn't look like it survives very long, on the order of less than an hour or so. Plastic and metal, they could recover it for up to several days on plastic and metal. And then copper surfaces, almost right away they couldn't recover it. That plays into people worrying about their mail and boxes being delivered. So it doesn't seem like there's the significant likelihood for transmission or survivability of the virus is on cardboard. The other question becomes fabric, and could it get on
Mm.
someone's coat or clothes and then be brought home and then transmitted around? And I don't know that we know that just yet, but based on how it does survives on cardboard for not very long, it's unlikely to last long on
Hmm.
fabric or clothing.
That's very practical information for us to
Yeah.
know.
And the other part of that is if it can't survive on plastic and metal, it can survive in office environments and keyboards and things like that.
Yeah.
So careful about hand washing and wiping down surfaces in communal areas.
Now I'm going to be wiping down my laptop as soon as this is done. So our last question is from Twitter, and it's from Nikolai from California. And he's asking, what do we have to do to stop the next COVID? So in the last 20 years, we've had this is what, number 4 or 5 pandemic. And then as you mentioned, this is the most severe one that we've dealt with in a century. But so what do we have to do as a society that in 10 years, 20 years, whatever time frame, we can prevent the next pandemic from happening?
It's a great question. So if you look at over the past 30 or 40 years, we've had multiple pandemics. HIV was one of the more recent ones. Again, it's transmitted differently. It affects people differently, but it is spread globally from initially not being part of our viral knowledge. Ebola is another one that's sort of emerged. There are other respiratory viruses that are similar to SARS. There's one that originates in the Middle East. There are other viruses that are transmitted by mosquitoes that have evolved. West Nile wasn't around 20 years ago. Zika wasn't around at significant rates until 3 or 4 years ago. As an example, West Nile started in a region of North Africa named for the Nile, and then made its way across Europe and then to North America, and then about 20 years ago made its way across North America, and it has seasonal outbreaks, and we see it regularly from an infectious disease perspective. It's transmitted by mosquitoes. So there are more outbreaks of these viruses and spread of these viruses than people may be aware of in the media. The other aspect is that there are researchers who are going to the hosts of these viruses, bats, other mammals, including civet cats and chimpanzees, and looking to see what other viruses do they have that have the potential to jump across to humans again. And the short answer is that there's lots of other viruses that are out there and other mammalian hosts. So there's potential for lots of these viruses to circulate widely in the foreseeable future, especially as there's more environmental change and we have more. Some of the thought, especially with HIV, was that the initial host was a chimpanzee, but as people went more into the chimpanzee's territory and consumed the chimpanzee for meat, essentially, that they then acquired the virus. So as we encroach upon other mammals' environments, there's more likelihood that we may acquire some of these viruses. So in order to prepare for these, again, it takes being sort of forewarned that there's the possibility this can happen, developing our public health infrastructure, developing our responsiveness and our supply of medications and medical equipment and health systems in case we face another pandemic like this. The public health response in the United States is largely left up to the individual states. Maybe it's time that we develop more of a cohesive national public health effort. A lot of our healthcare system is driven by profit, and they operate on fairly thin margins in terms of availability in hospital. Maybe we need to develop a system where they have a little more capacity to address these pandemics or surges. So there's a lot of aspects to that. I hope that made some sense. It was
definitely. I think for me, obviously, it's a tragedy what's happening. People are dying, and particularly it's hard for me to stomach is our healthcare colleagues that are going to be continually faced with it and being exposed to this and potentially getting severe complications and dying from this for however long this lasts. But at the same time, it seems like this could be an opportunity for us to prioritize science, prioritize medicine, the development of vaccines. Could be a opportunity to have a national and worldwide dialogue on, like you're saying, encroaching on wild spaces, encroaching on these animals and vectors of these viruses that have been evolving for millions of years. So it seems that people are responding to that. I think overwhelmingly people understand that there are people who know what's going on, people who are trying to help understand where these things are coming from and how to get ourselves out of this, and that ultimately it will come down to prevention in the future rather than scrambling to develop a vaccine in the midst of a pandemic.
Mm-hmm. That's absolutely right, and I think that it speaks to two other aspects of the pandemic. One, and emerging viruses like this. One is that they tend to emerge in developing parts of the world, and the other aspect is that developing parts of the world tend to be hardest hit by these types of pandemics. Mm-hmm. So it is important for us as a nation and a world to sort of try to strengthen the health systems of developing parts of the world. And particularly, I work in Malawi in sub-Saharan Africa, and unfortunately the health system there is completely unprepared for anything of this magnitude. And we saw this 3-4 years ago in 2016 with Ebola, where it emerged in the Democratic Republic of Congo and then spread to local, and then Liberia and Sierra Leone and nearby countries. And then from there, it can spread globally, especially in this day and age of widespread international travel. So I think it helps to think not just nationally and from our system and being proactive or preventive, but also sort of thinking globally. Because as we saw, this emerged from a market in Wuhan, China. I don't think I had heard of Wuhan before this. And then you could see it spreading across the globe, mm-hmm. and now it's here. It's part of our lives.
So we're all connected, and we're all going to try to get through this together.
Yes.
Dr. Tymchuk, we really, really appreciate your expertise, helping us understand where we are and the path forward. We hope that you stay safe in your job. We hope that we see some promising results from some of the trials that you're involved in. And we, again, want to thank you for your time.
Of course. It's been a pleasure. Great talking with you.
Of course. Yeah, we hope to have you back soon on the channel.
Anytime.
All right. Take care, everybody. If you made it this far, thank you for sticking around. Check out the video I made on Italy's high death rate, as it does tie in very well to this episode. You can find it by clicking here or here. It might be flipped. It'll be up there. You can also see my discussion on hydroxychloroquine by clicking here, probably. If you want to see more content like this, please consider subscribing to the channel. And as always, thank you for continuing to learn with me as we navigate these uncertain times together. Until next time, stay safe, stay well, and I will see you soon.